Imagine doing everything right. You wake up early to take your thyroid pill on a completely empty stomach, just like your doctor ordered. You take your hormone replacement therapy to manage your menopause. You're putting in the work.
Right, you're following the instructions.
Exactly. Yet, despite all this, your brain fog is somehow worse than ever. You are completely exhausted by 2 p.m., and you're inexplicably gaining weight. You probably think your body is failing you, or, I don't know, that the medications are just duds.
It's just so common.
Yeah. But actually, your 2 daily medications might be quietly suffocating each other right there in your bloodstream.
It is an incredibly frustrating scenario, and it happens, honestly, every single day. We are looking at 2 highly common treatments here. So levothyroxine for an underactive thyroid and estrogen for menopause. And they directly collide if you don't know the precise biological rules for combining them.
And that collision is exactly what we are untangling in today's deep dive. We're looking really closely at how you should manage the timing and the dosage of your HRT if you are already taking levothyroxine.
It's a very specific mission, but a vital one.
It really is. And to get to the bottom of this, we pulled a huge stack of clinical guidelines from the Society for Endocrinology, resources from the NHS, treatment protocols from Henry Ford Health, and some really pivotal pharmacological studies that detail exactly what happens in your body when these hormones mix.
Yeah, and the reason this deep dive is so crucial for anyone navigating midlife health is the massive symptom overlap. Between hypothyroidism and underactive thyroid and menopause.
They look so similar on the surface.
Exactly. Both conditions cause profound fatigue, weight changes, low mood, and, just feeling constantly cold.
Which makes it a complete diagnostic nightmare. You start your HRT and suddenly feel exhausted again. The logical leap for you is to think, oh, the menopause is just getting more severe, or my HRT dose is too low.
Right. You blame the new medication.
Yeah. But the reality is often a chemical traffic jam. But before we get into the crash itself, we need to understand the primary vehicle involved here. Levothyroxine on its own it's a notoriously demanding medication.
It really is the prima donna of pills. It requires a highly specific environment just to make it into your system. To understand why, we kind of have to look at its structure.
Okay, let's break that down.
So levothyroxine is a synthetic version of thyroxine, which is the main hormone, T4, that your thyroid gland produces naturally. But the synthetic pill form has incredibly poor bioavailability.
Meaning it's just hard to absorb.
Exactly. It is extremely difficult for your gut to absorb the active drug and move it across the intestinal wall and into your bloodstream.
I was actually reading the Henry Ford Health guidelines on this.
Right.
And the best way to visualize a levothyroxine tablet is like a VIP celebrity who demands an entirely empty elevator.
I love that analogy.
Right. That elevator's your stomach. If absolutely any other molecule gets into the elevator with this celebrity, they refuse to ride. They just bounce around the lobby and never make it up to the penthouse, which is your bloodstream.
Scientifically, that is exactly what happens. Any other molecule in the stomach can physically bind to the levothyroxine. According to the standard endocrine guidelines, you have to take it on a completely empty stomach, usually like 30 to 60 minutes before you eat breakfast.
And the list of things that can interfere with it is staggering. We need to be specific here because it's not just a matter of, avoiding a heavy meal.
No, not at all. Even a morning coffee is a problem.
Wait, really? Just black coffee?
Yep. The caffeine speeds up your digestion, rushing the pill through your system before it can even be absorbed. And if you add a splash of milk or cream to that coffee, you introduce calcium.
And calcium is a big offender.
Huge. Calcium directly chelates with the thyroid hormone in your gut. It binds to it and creates this bulky, insoluble complex that your body simply cannot absorb. It physically cannot pass through the intestinal lining.
So the celebrity basically gets handcuffed to a fan in the elevator.
Exactly. And you just excrete the medication without it ever doing its job. The same goes for calcium supplements, iron supplements, multivitamins, and antacids. The Pharmacy Times data shows that taking something as simple as an over-the-counter calcium carbonate antacid can decrease your levothyroxine absorption by a full third.
A third? That's massive. Wait, I need to push back on this morning routine requirement for a second.
Sure.
What if you just aren't a morning person?
Yeah.
Or your mornings involve, like, wrangling toddlers, packing lunches, and rushing out the door.
Yeah.
The idea of timing a pill exactly an hour before a splash of milk in your coffee feels entirely unmanageable for a lot of people. Are they just doomed to have poorly absorbed medication?
Not at all. The clinical guidelines actually offer a highly effective alternative for that exact situation, and that's bedtime dosing.
Oh, really?
At night.
Yeah.
Research shows that taking levothyroxine right before you go to sleep can result in absorbing in levels that are just as good, sometimes even better, than morning dosing. But you still have to maintain that strict isolation protocol. You must take it at least 4 hours after your last meal or snack.
4 hours. Okay, so if I finish a late dinner or, I don't know, have a bowl of ice cream at 8 p.m., I cannot take my thyroid pill until midnight.
Right. The 4-hour window is a biological necessity. It takes about that long for the human stomach to completely empty its contents into the small intestine. You're basically ensuring that the gastric elevator is completely empty before sending the levothyroxine in.
Okay, so the gut demands total isolation. I get that. But let's bring HRT back into the picture because this is where the plot thickens.
This is the tricky part.
Yeah, because if I take my thyroid pill at 6 a.m. and my estrogen tablet at 9 p.m., they're separated by 15 hours. They never physically touch in my stomach. So how are they canceling each other out?
Because the collision we are most concerned about doesn't happen in your stomach. It happens in your bloodstream, and it's orchestrated by your liver.
The liver. Okay.
Yeah. When you take oral estrogen, so a traditional HRT pill that you swallow, it travels down your digestive tract and is absorbed into the portal vein.
And the portal vein is essentially a direct highway from your gut straight to your liver, right?
That's right. Anything absorbed from your stomach and intestines hits the liver first before it circulates to the rest of your body. This is called first-pass metabolism. Swallowing an estrogen pill delivers a massive, concentrated bolus of hormones directly to the liver all at once.
And I'm guessing the liver isn't used to seeing hormone spikes like that coming from the digestive tract?
No, not at all. Naturally produced estrogen trickles into the bloodstream from the ovaries. So when the liver gets slammed with this oral dose, it reacts defensively.
It freaks out.
It totally freaks out. It dramatically ramps up the production of a specific transport protein called a thyroxine-binding globulin, or TBG.
Okay, let's visualize this because TDG is the real culprit here. Think of your free active thyroid hormones as passengers trying to get to work. Their job is to get inside your cells to regulate your metabolism, your energy, your body temperature. Right. But hormones are fat-soluble. They can't just float freely in the watery environment of your blood. They need a transport vehicle. So the TBG proteins are taxicabs. Usually, your body maintains a perfect ratio of passengers to taxis. The hormones catch a ride, get dropped off at the cells, and your metabolism purrs along.
But oral estrogen ruins that ratio completely. That first-pass liver metabolism suddenly floods the streets with thousands of extra, completely empty taxi cabs.
And what happens when there are thousands of empty taxis circling the block? All your available thyroid hormone passengers get scooped up, they get locked inside these TBG taxis.
Yeah.
And as long as they're riding around bound to that protein, they aren't doing their jobs. They can't exit the taxi to enter your cells.
Yeah.
You are left with very little free thyroid hormone actually doing the work.
The clinical data on this mechanism is undeniable. There's a pivotal 2007 study published in the Journal of Clinical Endocrinology and Metabolism, and they tracked postmenopausal women who were on stable doses of levothyroxine. When these women started taking oral estradiol, their TDG levels, those empty taxicabs, surged by 49%.
49%. Wait, that completely strips the active hormones from the system.
It does. It creates an immediate state of hypothyroidism. The free T4 in the blood drops. Your pituitary gland, which acts as the thermostat for your endocrine system, senses the drop. It starts pumping out more TSH, thyroid-stimulating hormone, basically screaming at the thyroid gland to produce more.
But the thyroid can't.
Exactly. Because the patient's thyroid is underactive or surgically removed, the body cannot naturally produce more to compensate. Functionally, that previously perfect levothyroxine dose becomes completely inadequate the moment TBG climbs.
And boom, the chemical traffic jam brings everything to a halt, the fatigue sets back in, the brain fog returns. And because you just started your menopause treatment, you blame the HRT. You think, well, estrogen just doesn't work for me.
But the estrogen is working fine. It has simply hijacked the thyroid medication.
So what's the move here? Do you have to choose between treating your hot flashes and having a functioning metabolism?
Not at all. There is a major biological workaround, and it comes down to delivery. It is not about whether you can take HRT. It is entirely about how that HRT enters your body.
The route matters.
The route changes the entire chemical reaction. If you use transdermal estrogen, meaning you deliver the hormone through the skin using patches, gels, or sprays, It absorbs directly into the systemic bloodstream.
Oh, I see.
Yeah, it completely bypasses the portal vein. It bypasses that first-pass metabolism in the liver.
Because it's absorbing through the capillaries in your skin, it just joins the general blood circulation.
Hmm.
The liver never gets that concentrated, sudden hit of estrogen, so it never panics and floods the streets with extra TBG taxicabs.
Exactly. That same 2007 study proved this. They compared the oral estrogen users to a group using a transdermal patch. While the oral tablets caused that 49% spike in TBG, the transdermal options only raised it by roughly 10%.
10% compared to 49% is a massive difference.
It's huge, and practically speaking, a 10% increase has almost no clinical effect on your circulating thyroid hormone. Wow.
For the vast majority of women on levothyroxine, simply changing their HRT prescription from a daily pill to a transdermal patch, a gel like Ostrogel, or a spray like Lenzetto completely solves the clash. The thyroid medication remains stable, the taxicabs stay in the garage, and the menopause symptoms are treated.
That is a total paradigm shift. It's just a simple switch in delivery, but it saves you from months of chasing your tail with blood tests and dose adjustments.
It really does.
But I have to ask about the other hormones in the mix, because HRT isn't just systemic estrogen. If a woman still has a uterus, she needs progesterone to protect her uterine lining from thickening.
Very true.
Or what if she's using localized vaginal estrogen to treat genitourinary symptoms like, dryness or frequent UTIs? Do those treatments spawn more taxicabs?
That is a vital distinction, and the short answer is no.
Oh, yeah. The traffic jam is caused exclusively by oral estrogen. Micronized progesterone, which is the body-identical form often prescribed alongside estrogen, does not raise TBG levels. Even the older synthetic progestins do not have this independent effect on the liver's binding proteins.
So you can take your progesterone capsule orally before bed without worrying about your thyroid.
Correct. And the same biological logic applies to vaginal estrogen. Low-dose vaginal inserts, creams, or rings have negligible systemic absorption.
Because they stay local.
Exactly. They are designed to act locally on the vaginal and urethral tissues. They do not pass through the liver in a concentrated dose, so they do not alter your thyroxine-binding globulin. If you are on levothyroxine, you do not need to panic about medication clashes just because you started a vaginal estrogen cream.
That brings a lot of peace of mind. But we do have to look at the reality of medical care. Transdermal estrogen is fantastic, but it's just not an option for everyone.
Right.
Some people have severe skin allergies to the patch adhesives. Sometimes the gels don't absorb well for a specific patient. Or maybe a doctor determines that an oral HRT tablet is the absolute best option for a patient's specific medical profile. If you absolutely must take both levothyroxine and oral estrogen, how do you manage that safely?
You can absolutely manage it, but it requires strict adherence to a routine. We can break this down into 3 golden rules of timing and tweaking.
Okay, let's hear them.
Rule number 1 is separation. Even though the main collision happens in the liver via the bloodstream, you still cannot take these 2 pills at the same time because of the gut absorption issues we discussed earlier. You must separate your levothyroxine and your oral estrogen by at least 4 hours.
Right, so we're back to the VIP elevator. You don't want the physical estrogen tablet dissolving in your stomach and interfering with the levothyroxine trying to cross the intestinal wall.
Exactly. Separation handles the gut. Rule number 2 is anticipating the blood collision. If you start oral HRT, you must go in knowing that your current levothyroxine dose will become insufficient because of the incoming TBG spike.
It's guaranteed to happen.
Pretty much. Clinical data suggests most women will need an increase of 25 to 50 micrograms in their daily levothyroxine dose to overcome the extra binding proteins.
Just to overpower the extra anti-taxis, you have to add more passengers to the system.
Yes. You provide enough extra thyroid hormone so that even after the taxis are full, there is still enough free hormone left over to enter your cells. Your doctor should proactively prepare you for this dosage increase.
Okay.
But rule number 3 is where things often go wrong, and that's the timeline. You cannot just guess your new dose, and you absolutely cannot test your blood too early.
Why is that? Like if I start an oral estrogen pill and 3 weeks later I feel sluggish and awful, why can't I just go to the lab, get a blood test, and have my doctor raise my thyroid dose right then?
Because levothyroxine has an exceptionally long half-life in the human body. It's about 7 days.
7 days.
Yeah. The half-life is the time it takes for your body to clear exactly half of the drug from your system. Think of it like a slow-draining bathtub. If the drain is slow and you keep running the faucet every single day by taking a pill, the water level, the medication in your blood is constantly layering and rising.
So if I change a dose or introduce a disruptor like estrogen, it takes a long time for the water level in the tub to settle into a new, stable baseline.
Exactly. It takes approximately 5 half-lives for levothyroxine to reach a steady state in the blood. 5 times 7 days is 35 days, or 5 weeks.
Wow.
If you test your blood at 2 or 3 weeks, you are testing while the water is still rising. You're capturing a snapshot of a moving target.
Let's map out what happens if you ignore that.
Yeah.
You go in at week 3 feeling terrible.
Yeah.
The lab shows your free thyroid hormones are low. The doctor says, okay, let's increase your dose by 50 micrograms. But your body hadn't actually finished processing the first change yet.
Exactly. The doctor increases your dose based on an incomplete picture. Fast forward another month, your blood levels finally stabilize, but now they are stabilizing with that massive extra 50 microgram dose on top of what was already building up.
Oh, no.
Suddenly, you swing in the opposite direction. You are hyperthyroid. Your heart is racing, you have anxiety, you can't sleep, you're sweating.
A total yo-yo effect, all because you didn't wait for the bathtub to settle.
Right. The NHS Specialist Pharmacy Services and the Society for Endocrinology have very rigid protocols to prevent this. After starting or changing any oral estrogen, you must wait a minimum of 6 to 8 weeks. Then and only then should you have your TSH and free OT4 levels rechecked.
Man, 6 to 8 weeks of waiting when you feel suboptimal requires a lot of patience.
It's a really difficult waiting period, I know, but it is a medical necessity. Testing any earlier guarantees inaccurate data, which guarantees incorrect dosing.
This has been a massive untangling of a very common problem. Let's make sure we've captured the essential roadmap for anyone listening.
Sounds good.
First, levothyroxine demands an empty stomach to absorb properly. It needs that VIP elevator, whether you take it in the morning or do strict 4-hour fasting before bed. Second, introducing an oral estrogen pill acts as a major disruptor, triggering your liver to produce proteins that lock up your active thyroid hormone.
And you can bypass that liver disruption almost entirely by utilizing transdermal HRT, so patches, gels, or sprays which absorb straight through the skin.
And finally, if oral HRT is the best or only route for you, you need to enforce a 4-hour separation between the pills, anticipate a thyroid dose increase, and practice the 6 to 8 week patience protocol before retesting your blood.
It takes coordination, definitely, but managing both conditions effectively is entirely achievable once you understand the mechanics.
Now, before we sign off, there is one final piece of research in these sources that completely flips the script on everything we've just discussed.
Oh, this part is fascinating.
We've spent this entire deep dive looking at how menopause treatments disrupt the thyroid. But the endocrine system is a two-way street.
It is, and this highlights how interconnected our hormones truly are. Just as estrogen impacts your thyroid function, your thyroid directly impacts your estrogen levels.
Break that down for us. How does my thyroid impact my estrogen?
Well, if your hypothyroidism is untreated or undertreated, say your levothyroxine dose is just slightly too low, it physically slows down your basal metabolic rate.
Right, everything slows down.
That includes the metabolic rate of your liver. One of your liver's primary jobs is clearing excess, used up estrogen from your bloodstream. A sluggish liver means that clearance process is delayed.
Wait, so having an underactive thyroid actually traps estrogen in your body for longer than it should be there?
Yes, it slows the clearance rate significantly. This can lead to higher circulating estradiol levels. For a woman in perimenopause, this can really amplify estrogen-dominant symptoms.
Like what?
It can worsen breast tenderness, cause heavier menstrual bleeding, and intensify mood swings. The lack of thyroid hormone is artificially inflating the estrogen levels.
That is wild. If your thyroid is underactive, your liver slows down, which means that estrogen sticks around much longer, amplifying your menopause symptoms. It turns out fixing your thyroid might just be the secret to balancing your estrogen.
It's all connected.
Something to really think about next time you reach for that pill bottle. Thanks for joining us on this deep dive.